This is really a big deal. We wanted to present it first here at ADAO because of the multi-interest nature of the group. We have physicians, we have basic scientists, we have industrial hygienists, we have families, we have patients. In medical things, we talk about financial conflicts of interest. I don't have any. So there's nothing to disclose. That's an important thing to know and will become more important in the future. Second thing I want to touch on briefly before going through these slides. Peg Seminario mentioned that it's like 3 decades, and I was sure she was mistaken, but when I add up the years, there are many of us in this room who have been fighting this fight for 30 years, and which leads me to the third point. That's why I'm so damn mad. Because these congressmen and senators who talk to us nicely and say, oh, we're outraged, we're upset, you know, it's time to stop this, still keep doing the same thing. So I think, did anybody see Caddyshack, that movie, Caddyshack? Do you remember when Mr. Hartunian brought in Randy Quaid, wasn't it Randy Quaid, the lawyer, and he tried reasoning with him, and then he asked Mr. Hartunian to leave, and he reached in his briefcase and took out a baseball bat and started beating the table with it, and he said, now let me reason with you in my own way. I think we have to start doing that. Early diagnosis of asbestos diseases is really very important. When I trained at the University of Michigan 30 years ago, we were told that you tell somebody that they have asbestosis and tell them to go home and get their papers in order, and they might get lung cancer, they might get colon cancer, and God forbid they might get mesothelioma, but their lives are pretty much done. Well, what I've learned in the last 30 years is that's not true. Not only is early diagnosis important to help the individual patient, and Dr. Levin mentioned that he found in Libby that there was a lot of asthma among some of the asbestos patients. In Detroit, we use Monaco. We have used a lot of Monaco, which is a product that contains a lot of Libby asbestos. And we've been seeing this asthma as well for the last 20 years or so. Most public health agencies and regulatory agencies use what's called the B reading system. The B reading system is a way of looking at chest x-rays and classifying them for scarring in the lungs from either silica or asbestos or other dust-caused diseases of the airway. And it was developed 40 years ago and really hasn't changed that much. There are some revisions, but it's really not much at all. So at Karmanos Cancer Institute, which is the home of the NCVAC, we like to call it the NCVAC, the National Center for Vermiculite and Asbestos-Related Cancers, we've developed a number of advances in the diagnosis and treatment of asbestos-related diseases, including radiography. Some of you may recall that we published an article in the New England Journal of Medicine a couple of years ago looking at the role of osteopontin, which is a protein in the diagnosis of asbestos-related mesothelioma. And we've also published soluble mesothelioma-related peptide, which is known commercially as the Mesomark, which we think is a terrific test as well. We've worked with Dr. Pass on both of those from NYU, and we now are entering into the field of radiography, using all of these aspects of diagnosis and treatment to better treat and better diagnose. So this is a regular sort of chest x-ray that is used in the diagnosis of asbestos-related diseases. It's called a PAN lateral, or PHS, meaning that it's taken from the back to the front, posterior to the anterior. And this is the basis on which the diagnosis of asbestos is largely made administratively and legally and for regulatory purposes. If you showed this to a regular radiologist, the regular radiologist would say, well, there's some heavy markings, maybe there's some honeycombing, maybe there's some changes of this, but it's a non-acute x-ray. These are probably scarring for somebody who's trained. There's probably a pleural plaque along here. But in general, this is the basis on which everything is based right now. And it's crazy. It's like basing cardiac diagnostics on the 1955 EKG instead of catheterization and all this sort of thing. All right, so what I'm going to first try and give you an idea of is a pleural plaque. This sort of shiny silvery area is a plaque. It's a thickening on the covering of the lung that's caused by asbestos. And when we look for pleural plaque, the Nazis used to call plaques beauty marks of asbestos. I don't need to say any more than it was the Nazis who did that. But you'll find in many legal proceedings, the defense attorneys will say, well, doctor, isn't this plaque just a beauty mark? And when I'm asked, of course, I point out where that thought came from. But it can cause significant pain, it can cause trouble breathing, and it can be the place from which mesothelioma arises. So radiographic detection of pleural plaques is an attempt to try and find this without actually having to open up the chest. Now, this is the next step in technology. These are called oblique x-rays. These are regular x-rays And it's an attempt to show the thickening on the covering of the lung. The picture at the bottom is a CAT scan, which shows pleural plaquing. That's the area with the little lines where it's a little bit thicker. But it's still, you can see that it doesn't tell you very much. So at Karmanos, what we did is we decided to process the CAT scan through a machine using a software program called a Vitrea software program. And again, by way of disclosure, I've never even met anybody from the Vitrea company. But it's used in reconstructing hearts for cardiac angiography. So you see that area with a little blue line? That's a pleural plaque. Well, you can see that's significantly better than what you're seeing here or here. It's significantly better, but it really isn't all that good. So we were able to colorize it and come up with this. Now, this, for the non-radiant, for almost any physician to look at this, this is almost like looking at an anatomy book. And to look at the pleural plaques, once you see them here, where they're outlined, you can go back and sort of fit them in. But this basically elucidates where pleural plaques are, how big they are. We can measure them. We can measure volumes of pleural plaques. We have a paper submitted to the peer-reviewed literature right now where we have measured increasing volumes in pleural plaques over a 4-year period. So this is really quite remarkable. And the use of this technology, actually use this technique, should make the entire medical, legal, and regulatory approach to radiography and asbestos obsolete. Now, we also know that asbestosis causes pulmonary fibrosis. This is what a scarred up lung looks like. It's, without taking you through what a non-scarred lung looks like, this is a scarred up lung. And again, through a chest x-ray, the attempt is to try and duplicate and find out through the use of a picture what is happening anatomically. So this would be a chest x-ray of a scarred up lung. This is the lung cut in section so you can see the scarring. This is the x-ray. It looks sort of cloudy, and there's this elaborate grading system on how much scarring there actually is there and what shapes the scars are. But there have been studies which show how inaccurate this is, how variable it is. The same reader will read the film differently if it's done at a different time of the day. There's room for enormous fraud. Fraud meaning intentional bad reading. There's enormous room for unintentional bad readings. So it's not very good, but it's what the government and the court system have asked us to depend on. And it's garbage. This is the next step up in technology. This is still not approved by the regulatory agencies as being usable, or the legal system in most cases. But this is, you can see along the bottom, there's some scarring there. This is a normal CAT scan. This is a regular CAT scan. This is what we're doing at Karmanos. Where it's green is where the scarring is. We can actually determine through the use of the computer in these units of measurement called Hounsfield units. They're units of measurement of the change in the consistency of the lung tissue on how much scarring there actually is in the lung. We can tell you a percentage. This is another way to look at it through the other view with color. Again, normal. Now, we were taught, when Steve Levin and I were in medical school, and Arthur Frank, we were taught, and Dr. Cameron, I think a few years after us, but we were all taught that only about 7% of cases of asbestosis will show scarring on one side of the lung. But that figure came from using an old, antiquated technology, the X-ray. What we found, just anecdotally, is that there are probably a lot more cases of scarring on one lung than previously believed when you look at it using 21st century technology. Now, this is a very interesting thing. We have a paper in the peer-reviewed process right now, so I can't give you too much detail on this. But this is another technique where we pull the lungs out of the thoracic cavity and found what are called rib erosions. What are rib erosions? We think that rib erosions are places where the plaques are rubbing against the inside of the rib and may explain some of the intractable pain that patients with asbestos-related plaques and mesothelioma get. What we also do with these images is rotate them in space. You can see how it's, there's a little bit of an angle, those yellow lines. We actually can take the entire lung and move it up and down and around. It's incredible. It's like Star Trek. If you think Star Trek's incredible, I guess it's a little dated. All right, this was I can look here now. A volume-rendered chest CT with mixed plaques. In other words, the plaques, some were calcified, some were not. But you can see them overlying the inside of the rib there. And there's another erosion. All right, this is really something. This has actually been presented at a press conference already, so this is not a violation of HIPAA, but I want you to know about this. So I want you to know about this. These are the lungs of a patient who has received a fair amount of publicity of ours. I'm not going to mention his name, but who works in a federal institution. And we discovered through the use of this 3D technology 4 lung nodules. Now, generally in lung cancer medicine and asbestos medicine, 4 nodules is better than 1. Because when you have a single pulmonary nodule, you worry more about lung cancer. When you have a bunch of them, you think of something else. Well, the problem is with people with asbestos exposure is that they can have a bunch because they're exposed to other things other than the pure asbestos fiber. And they can cause those other nodules to occur, we believe. So the orange area here is airways. Let me go to the next slide. This is nodule 4, where the arrow is pointing to that. Can you see that little round thing? All right, nodule 4 is in the upper right. Actually, be the upper right, your upper right-hand corner. That nodule looks suspiciously malignant. Now, it's a little too small for us to go after with a needle right now to get a biopsy, and we're too unsure of what it is to go in and take it out. And it's a little bit too small to be detected with a PET scanner. It's positron emission tomography that some of you may know about. But it's very suspicious, so we're measuring the volume. We're actually measuring the volume of this nodule and following it along at 3-month intervals. And if it grows at the rate that we are afraid it might grow at, then we'll probably just take it out. To give you an idea about lung surfaces, you know, I told you how we're taking the lung and moving it in space. This is a color-coded lung surface. Those are scars along the bottom of the lung. And another thing we're doing, we have another paper in the peer-reviewed literature process right now, where we're actually quantifying the pleural plaque. For me, this is just incredible. I'm just dumbfounded to be able to tell you about this. The blue area is the pleural plaque, and we can measure the volume. And as I mentioned earlier, we've actually serially over 4 years measured the volume in a couple of patients, but one we're presenting in the medical literature. And we can see where some agents heretofore not classified as asbestos cause the rapid growth of plaques and intractable pleural pain. Included among the significant advances, you can read this. Look, what we're doing is we've discovered something really exciting at Karmanos, and it really, assuming we're validated through the peer review process, and we have some funding from the EPA right now to do validation studies, and if anybody knows a board-certified radiologist who wants to volunteer for one of our validation studies in terms of finding other readers who will interpret these films the same way we do for consistency's purposes, then we're looking for people like that. But that's the validation of our interpretation scheme, if you will, or interpretation. This radiographic technique of looking at asbestos-related diseases, at pleural plaques, at solitary pulmonary nodules, and at lung cancers is an exciting, enormous leap forward in the practice of asbestos medicine. And we really do a heck of a job, if I say so, myself at Karmanos. We've introduced or participated in the introduction of 2 tumor markers, one of which is probably quite valid as a screener. And we do see people from, the ladies from England who are here, I thought they were from Australia because in candor, we take care of people from as far away as Australia. And you sounded like one of our patients from Australia. So that's basically what I wanted you to know. This is extremely important. One of the things that you should know from this is that when you hear somebody talking about, oh, we need a B reading, you don't need a B reading. You need a 64-slice CAT scan that's enhanced, and this is the thing. This is where it's at. We did take a chest X-ray offline for this presentation from the UK, and I have to acknowledge the special help of my 12-year-old daughter, who taught me what a right click is, who put together this presentation.